Like Randy, I'd like to begin by thanking the National History Center, my fellow panelists, and Congressional staff and other invited guests for your time and attention. What can history teach us as we try to make sense of the contemporary Ebola crisis? One important lesson is that trust and community empowerment are crucial to the success of public health efforts. In early March, when I began planning a trip to Liberia, the international media was mostly quiet about the slow burn of the Ebola epidemic in West Africa. When I arrived in Monrovia in June and awoke one morning to the headline, "Ebola in Town," the news was cause for concern. A nurse working at Redemption Hospital, the second largest referral hospital in Liberia located in New Crewtown, outside Monrovia, had contracted the disease and died. For the first time, the disease had reached a crowded urban area that contains more than 1/3 of Liberia's population. Only in late July, however, when word came that 2 American healthcare workers in Liberia had become infected, did the outbreak finally draw global headlines. Ignited by media attention, fear erupted and spread faster than the virus itself. Like the Ebola virus, fear has its own ecology. What writer Mike Davis calls the ecology of fear is different in the country than in the city. Fear varies by cultural tradition and religious belief. Rich people experience fear differently than poor people, and fear changes across time. Mistrust and disbelief were part of the ecology of fear in Liberia that shaped initial reactions toward the outbreak. While a decade of peace has reigned in Liberia, the memory of a 14-year brutal civil war, which took the lives of an estimated 250,000 people, left the country's infrastructure in ruins, and fueled corruption, has greatly eroded trust in government. Such mistrust spawned numerous rumors about whether Ebola was real. Mistrust fostered public denial and sent patients underground, exacerbating the spread of the virus. The history and memory of past medical encounters in Liberia also contributed to the ecology of fear. This is not the first time a disease outbreak has made West Africa the subject of global attention and concern. Over the course of 1928 and 1929, for instance, a flare-up of yellow fever in West Africa resulted in the deaths of prominent American, British, and Japanese medical researchers and educational advisors. It prompted the U.S. government and the then League of Nations to put intense political pressure on the Liberian government to address the, quote, unsanitary conditions deemed a menace to the lives of the citizens and subjects of foreign nations who reside in Liberia. The yellow fever outbreak signified a major threat to American business in Liberia. In 1926, Firestone Tire and Rubber Company gained access to 1 million acres of land to supply the United States with rubber free from British control. Knowledge of tropical medicine was vital to the company's success. It was, in fact, a 1926 Harvard medical expedition to Liberia, undertaken on behalf of Firestone, that had brought me there. In 1926, the 8-member team had traveled for 4 months through the Liberian interior, collecting blood, tumors, urine, and photographs of diverse ethnic groups to assist Firestone in securing a healthy labor force. Some people ran away when they saw these strangers. The routes the expedition traveled were those used by European and West African slave traders, white missionaries, and Liberian soldiers recently sent to conquer the interior. Why stick around when strangers have been such potent contributors to the local ecology of fear? American medical research profited from the blood, parasites, and viruses collected on these expeditions. Such materials were the stuff of Nobel Prizes, professional prestige and fame, and medical breakthroughs that benefited people throughout the world. But biomedical research did little in return to help build medical knowledge and public health capacity within Liberia. In the 1930s, the U.S. State Department expressed grave concern that Firestone, whose plantation served as a laboratory for American scientific and medical research, has, quote, not even had a resident doctor on his plantations to care for his many native workmen, end quote. It was an early experiment reliant largely upon private capital to advance global health, one that by the 1940s the U.S. government deemed a failure. In 1944, the U.S. Foreign Economics Administration sent an economic mission to Liberia to provide technical assistance and training in engineering, agriculture, and public health. It was an early experiment, the pilot for Truman's Point 4 program. The goal was to improve the health and well-being of the Liberian people, and significant gains were made. By the 1960s, Liberia had become an important economic, educational, and medical hub in West Africa. This progress would all come crashing down with the Civil War, as those with the education and means to do so fled the country. A new wave of land concessions in the name of development have been granted to multinational corporations seeking to extract Liberia's rich mineral and agricultural wealth. Yet investment in the country's medical infrastructure languishes. Before the Ebola outbreak, Liberia had fewer than 100 doctors for a population of over 4 million people. Liberia's healthcare infrastructure consists of an archipelago of private enclaves like Firestone, health clinics supported by NGOs such as Doctors Without Borders and Samaritan's Purse, and a few government hospitals which also rely upon NGOs to provide drugs and healthcare training. It is a system at once fragile and inadequate to meet the contemporary crisis. Remembering this history of development can help us understand why the current Ebola epidemic and the ecology of fear associated with it is unfolding as it is. In the United States, different histories and contemporary contexts shape the fears we see prevalent in public reactions since Ebola reached American shores. Fears of West Africa as the white man's grave, a view dating back to the 18th century, persist to this day. They lay behind, for example, Donald Trump's much publicized tweet, "Stop all flights from Ebola-infected countries or the plague will spread inside our borders," sent when Dr. Brent Blantley and fellow medical worker Nancy Ridable were flown to Atlanta in late July after becoming infected with the virus. These fears appear more recently in the stigmatization of Africans in the United States, where incidents have been reported of a Texas community college rejecting applicants from Nigeria and an elementary school in New Jersey telling 2 Rwandan students to stay home for fear of Ebola. It is fear, rather than informed medical opinion, that prompted public appeals for more stringent policies at the state and federal level for instituting travel bans, establishing mandatory quarantines for returning healthcare workers, and even denying visas for visitors from West African countries. The push to isolate and quarantine countries in containing epidemics fell out of favor in the late 19th century as global trade became critical to the U.S. economy. Even during the 2003 SARS epidemic, which involved an airborne communicable virus more highly contagious than Ebola, the U.S. did not institute either individual or population-based quarantines of exposed persons. Travel bans and quarantines will only hinder the free movement of people, supplies, and goods to and from Liberia and other West African countries, vital to the economy, health, and well-being of a nation with deep historical ties to the United States. Recent statistics from the WHO suggest that the number of new Ebola cases is declining in Liberia, from a high of 476 new cases per week in late August to 97 new cases in the first week of November. These numbers are indicative of a shift in public attitudes and behavior within Liberia that occurred after a military-enforced quarantine in August imposed on the residents of West Point, Monrovia's largest and poorest slum community, resulted in the shooting and death of a teenage boy. Within a few days after Shaki Kamara's death, President Ellen Johnson Sirleaf lifted the quarantine. Engagement, not of the Liberian military, but of church and community leaders, artists and musicians, radio DJs, and Liberian healthcare workers in the fight to contain Ebola has helped to build trust, dampen fears and disbelief, alter individual and cultural behaviors, and empower local community action. This is no time to let up on the U.S. support and aid in West Africa. While the number of new Ebola cases has stabilized in some districts in Guinea and declined in some districts in Liberia, a reversal in this trend is easily possible. Transmission rates continue to escalate in Sierra Leone. Stabilization in the number of new Ebola cases in parts of Liberia, even before the first Ebola treatment units built with the support of American aid and military troops were opened, suggest that a militarized biosecurity approach to the containment of emerging diseases, which has largely shaped U.S. funding and policies over the last decade, may not be the most effective long-term strategy to advance global health. Instead, evidence points to the value of investing in public health infrastructure, building medical knowledge and capacity within local communities to foster trust and meet the basic health needs of a population. Thank you.